Okay, I think we are live. Good morning, good afternoon, depending on where you are. We'll just give folks a moment to get connected. All right, I see the attendee numbers rising. So if you're just joining us, we'll be holding for a few moments to let people get connected to the webinar. Okay. Good morning and good afternoon, everyone. I see a number of folks have joined the webinar so far. We are going to go ahead and get started. We have probably some other folks still joining here. My name is Lisa Berry. I lead policy and partnerships here at Innovacer, and I'm going to be kicking us off on this webinar today about navigating CMS access and lead to CMS value-based care models out of the CMS Innovation Center. All right, let's go to the next slide, please. Joining me today are a couple of colleagues. Jonathan Blum, who is the co-founder and managing partner of Health Transformation Strategies and former principal deputy administrator and chief operating officer at CMS, as well as many other roles in and out of government for many years. Definitely an expert on CMS and CMS models. Jim Hong, our chief analytics officer at Innovacer, and Varun Paranjpe, who is our Senior Director of Product Marketing at Innovacer. So we're going to be talking about, again, CMS access and CMS lead, and generally the framing of where we are right now with these two pretty consequential CMS models that are launching either this year, very shortly in July, or early next year. And if you are someone who is working in the accountable care organization space, 6 months is not a very long time to get ready for a new model. So it probably feels really close coming up on us as you're working through all of the policy and operational decisions you have to make to get there. We're going to start out by talking to John. This is our agenda today. We'll talk a bit about the framing of the models. We'll talk about Innovacer's Atlas Population Health Operating System. We'll talk about specifics around how we think you can be successful in access and lead. And then we'll have a brief panel discussion where we talk more about some of these issues that we address in the first part of the webinar. I believe we will have the ability to take questions, I think, through the chat or through the Q&A. Can someone just confirm? Q&A. Looks like the Q&A is active here. So if something comes up for you during the webinar, go to that bottom rail and find the Q&A and enter your question there. We will try and catch up with it either live or after the webinar. Okay, great. So with that, next slide, please. So John, let me bring you up here. So first of all, I did a little introduction of you, but maybe you can just share a bit more with the audience about your background and your experience working with CMS for many years.
Sure, thanks, Lisa. I'm really happy to be here and look forward to the conversation. So I had the privilege of being at CMS for two tours, one from 2009 to 2014, where I led the Center for Medicare. And that was a time where we were launching the Innovation Center. We were launching some of the models that are still in place today, but also first take to models that have been refined. And I think for today's conversation continue to be refined. I came back to the agency in 2021 to 2025 to be the chief operating officer, and have seen CMS in kind of various phases of putting out new models, refining models, and thinking through how it can better support value-based care. So really happy to be here and look forward to the conversation.
Yeah, absolutely. So I think a number of folks who've worked at CMS and CMMI in the past, have published a sort of commentary on 15 years of the CMS Innovation Center and what works, what doesn't work. This is the headline here, is that CMS has spent 15 years learning what moves outcomes in Medicare, and access and lead are reflecting those lessons and looking at ways to support continuous tech-enabled outcome focused care at scale. Can you talk a bit about this perspective of looking back on 15 years, 15 plus years now of accountable care organizations and value-based care models?
I think a couple of things just to start the conversation. But CMS has kind of faced various tensions, various balances that it's tried to work through. The first balance is how much to define within tight regulation and create kind of single program standards versus how much flexibility and how much innovation does it want to see within those models. So I think part of the tension that CMS has tried to solve, continues to solve, is um, uh, who should be in the shared savings program, the kind of core ACO program, versus how we think about creating incentives for how to help organizations take on higher levels of financial risk. And I think in today's lead discussion, that tension continues to play out. A kind of second tension is how much risk to grant organizations, and what should the rules be in order to kind of manage that risk. And CMS has given permission to conveners to kind of bring organizations together to help manage that risk. But at the same time, that creates challenge around having providers feel the incentives, feel the risk, and kind of make delivery system changes around that. The third tension is how much deference to give the health system for how much control that it has in order to change the delivery system. Should CMS grant more waivers to help ACOs think about programs like taking away the 3-day stay requirement for skilled nursing services, putting in place more telemedicine authority in order to change care. And so that's been another tension that CMS continues to balance of kind of how much freedom to give organizations relative to current regulations. I think the last sort of challenge, not a tension, but a challenge point that CMS has faced is how do we communicate what is value-based care? And I think that CMS has not yet sort of found the right mark yet to really align how CMS providers, patients think about value-based care. And during my experience with CMS and traveling across the country, you ask the question to providers, how do you define value-based care? 10 different people, 10 different answers. And I think that that's a challenge for CMS. And more challenging is that beneficiaries don't understand what value-based care is. They get notices from their providers, they're in an ACO. That sounds threatening, that sounds ominous. My mom gets that letter every year and she calls me and says, what does this mean? I don't understand. This
Right.
is a big challenge for me. So I think those tensions, those challenges are still inherent to our conversation, but I think some of the core messages for the models coming out of CMS now is kind of further refinement to how we balance these tensions, clear definition for how we think about value-based care, but we're on a long journey.
Yeah, absolutely. I mean, when I think about what is value-based care today after 15, 20 plus years of this movement and this experiment that has gone beyond simple capitation to focus on, quality and outcomes, you come back to, and this may be a little bit provocative for the scale of this webinar, but infinite needs, finite resources, right? And we have been working on this for quite some time. And luckily we have learned some lessons that are being implemented and have been implemented over the last couple of years, including from the time when you were in your role, sort of extending the time frame of these models in this time period to understand whether things are actually working. Remember, the results don't show up in just a year or two. Sometimes it can take much longer to see how these things work. That long-term commitment here is a really, really important approach. Can you say anything about the continuation of priorities between administrations. That's been something that has been pretty notable, that we continue to see a focus on the value-based care and accountable care approaches that were started in the prior administration to the current one.
Yeah, I mean, despite political change and despite, you know, changes that we see, particularly around Medicaid and um, the health insurance coverage world, there is a lot of continuity between different teams, different policy changes within CMS for the Innovation Center agenda. I think you can draw a pretty straight line between, how the Innovation Center was first conceived during the Obama years to where we are today. And the agency certainly has gotten smarter. I think some of the models now coming out with LEAD have, kind of better benchmarking systems, better controls for how we think about code growth. And I think that most people that have served at CMS, particularly within the Innovation Center side, would say, yes, there's been changes for how we talk about some of the models, there's been changes for how we think about, kind of staffing and how to run the Innovation Center. But the models themselves of, purpose, how they evolve, particularly in the total cost of care construct, I think there is a very straight line between how these models were first conceived to how they continue to be refined and uh, most important, commitment to use the fee-for-service Medicare program as the core engine for how we test, for how we innovate, and how we think about building better incentives for total cost of care.
Wonderful. Okay, we are already going to move on to our next section here, and we'll hear from John later in the webinar when we do a little bit more of a dialogue between myself and John and Jim. So I'm going to hand it over now to Jim Hong, our Chief Analytics Officer. Jim.
All right, thanks, John and Lisa. And so I think I think John talked a lot about the intentions behind some of the new models and some of the tensions that CMS is grappling with to understand how to, enable value-based care. What we're going to talk about in this section is really what it takes to be successful under the models that they have released and or will be releasing. And so to do that, we're going to talk about our interpretation of what population health needs to look like, essentially a shift from pure technology to more of an operating system model. And so if we'll advance the slide here, I think the first thing that I want to introduce for the folks on this webinar is really Innovator's Atlas Population Health Operating System. And what I want the audience to sort of gravitate towards is really the bottom of the screen to start, which is the gravity layer. And that is our foundational layer that really kind of combines the unified data that you encounter within the healthcare ecosystem along with an AI orchestration platform. So that's really the bedrock of everything that exists as an operating system, upon which there are really kind of, if you gravitate towards the middle of the screen, three different aspects here. And what you have on the left here is a very traditional population health workflow that really has been differentiated through AI empowerment. That exists as sort of something that maybe all systems are somewhat familiar with, technology in the form of software workflows. Where I think the operating system really kind of shines in a different way is the next two here. In the middle, we have AI-enabled services through our Humvee division, which takes a lot of the data and forecasts forward all the actual prescriptions and predictions in terms of what could happen. And then finally, on the right here, you have managed programs, which is sort of through our Story Health division, which really takes all of that and then puts some real muscle behind the data and the insights and the forecasts into actually managing populations. All this can impact your populations, whether they're in VBC or fee-for-service. What you really see on the screen here is the core competency for Innovacer and something that really grounds us in the population health arena. And I think, to take this from a theoretical concept into real outcomes that have been delivered, if we'll go forward here, you can see that some of the examples of proof points where this operating system has really impacted everything from readmissions to avoidable hospitalizations and avoidable utilization to an overall improvement in global quality scores, right? And so this is the foundation that I think I want to make sure that everybody's aligned towards in terms of what is possible to make, programs like Access and Lead successful is really this operating system that can operate at three different levels, whether that's software, whether that's services, or whether that's truly managed programs. And so to really bring this into a much more concrete area, if we go forward and talk about Access directly, right? So I think the first thing that every organization could really is faced with is really kind of the two options that are in front of them. One, which is to partner with a participant in Access, and the other, which is to obviously not participate. And while on the surface, it might seem like that not participating is truly an option, from the various health systems that we've spoken to, really, I think option two here, don't participate, is not truly a neutral option. And we'll kind of talk about why. So when you do partner with a participant, there is a co-management revenue fee that can be sort of inserted into the equation without much risk, without much needing a building that's required from the health system. So that in itself is kind of the first sort of the pro for participating. On top of that, there is also the preservation of kind of the fee-for-service revenue that you're getting today. And then obviously there's the sort of the outcome and the cost. When you do not participate, while it seems like the most natural thing that disappears is the co-management revenue, really, and we'll talk about this on the next few slides, what I think Access really enables is almost, in essence, invites all manners of care and provider organizations to engage populations. And when that happens, it really kind of potentially redistributes the market share in terms of where fee-for-service dollars and current healthcare spending is happening. And so I think that's actually really kind of the more motivating factor in terms of where organizations should consider is what happens when you don't actually engage your population through Access and let that kind of, take shape however the other virtual care companies and technology companies might want to tackle patient populations. So if we'll advance to the next slide, I think when you partner with an organization like Innovacer, which is, an Access organization, what really kind of comes out of that is better patient relationships, ultimately better care delivered. There's obviously the financial aspect of it that we talked about on the previous slide, but really kind of it accelerates the CMS intentions behind the Access program. And so by taking the data platform, the operating system, and the AI-led care delivery, that ultimately means patients are retained and revenue is gained through existing market share of where healthcare dollar spending is happening, right? So if we advance a slide further, I think essentially, the playbook for how to be successful in Access really calls for these four pillars, which is being able to identify at-risk beneficiaries and engaging them and turning that eligibility into enrolled lives in an Access program. That is sort of the two pillars on the left that you see here in the amber and the pink. Then in delivering care, that's sort of the typical next step where you're taking those patient populations and ensuring that they have a much smarter care program and a care management deployment that's happening both during the encounters with healthcare entities, but also between visits. to really understand and help shape their behavior towards the outcomes that these programs are actually ultimately going to reward. And so that then brings us kind of to all the way to the right here, which is really measuring that impact, understanding how close or how much you've exceeded these performance targets, and then simplifying the reporting that comes out of it to really understand what is your benefit from engaging these patients and the impact that you've had. So these are kind of the four pillars that really lean into success with access program. And so they really dovetail with kind of the population health operating system and the mechanisms that we've talked about kind of a few slides back. And so what that ultimately means is then you have, as a healthcare system, you have the new revenue that's coming from the co-management, the $100 PMPY. You get to retain potentially the 100% of the fee-for-service dollars that's going into your system. You then have total visibility into everything that your patients are going through, every interaction, whether that's an interaction with your system, whether that's an interaction with the care management and access participant. And then ultimately, that means there's greater retention and there's greater loyalty with respect to where they're, procuring their healthcare services. And so that's really kind of the four pillars that we are enabling through technology, services, and managed programs. So from our perspective, the partner carries the risk. You guys, health systems will see the benefit. And I think again, just to double down and call back to kind of what enables all of this is really the healthcare operating system that is AI native, that unifies data through pre-built connectors and models and dashboards into proven results that we've seen in hospitalizations through Story Health, and the decade of experience that we are infusing into our AI-enabled approaches to engaging populations. Right. So ultimately, that kind of culminates in, we'll summarize this at a very financial view, which is if you are a health system with, let's say, 150,000 eligible CKM and eCKM patients, the natural $100 PMPY referral co-management fee is going to net you that 15 million in incremental high margin. We'll call it high margin revenue. Again, the risk to you is low. The build required is minimal or non-existent. So that's 15 million incremental high margin revenue. But more importantly, and this is the number on the right here, is the potential of defending that 1.5 billion fee for service revenue, assuming essentially, 10K per year in fee for service dollars of a beneficiary all within one health system, right? And so it's not purely just the potential upside on the left, which requires very little lift investment, but more importantly, the defense of the 1.5 billion on the right, assuming the current market share and spending for those beneficiaries. And so to really kind of encapsulate how this all plays out in the real world, if we go one slide further, I think this is our depiction of what it might look like for health systems if they choose to not participate, if they think about waiting in terms of engaging with access. And so again, starting on the left here, the baseline might be that 10K in revenue per beneficiary and fee-for-service dollars accruing to a specific health system. In this case, we're using an example of Acme Health System. What you might see in year one is that a new organization, Rainforest Health, or the equivalent of some virtual care company, may start engaging with those beneficiaries and might start capturing some revenue purely related to remote patient monitoring or complex care management. But then over time, as those relationships blossom and some steerage, sort of referral patterns start emerging, you might see that this new organization starts owning the primary care relationship and starts steering those patients into other places within the healthcare ecosystem. Ultimately, by year 5, you might see more of that erosion uh, where that patient's sort of experience now covers more diverse specialists and pharmacy revenue, thus kind of eroding that the where they're spending their healthcare dollars initially. And so that's kind of the depiction of what is a possible outcome. Not saying that this is going to be every outcome, but because access really opens the door for any organization to engage with these beneficiaries, there's really a potential for this for these healthcare dollars to essentially redistribute in the marketplace. And that's how we
Yeah,
sort of
Jim,
go back
let
to
me
the.
stop you right there really quick because we do have a question that's fairly relevant to this. I know we have to get to lead, but we
Yeah.
have a question asking where is the cost to the health system or medical group and how much? And I think we can answer that pretty easily. There is no immediate cost beyond what we have assessed as the cost of waiting and just waiting to see whether, different beneficiaries, different Medicare, original Medicare beneficiaries are pulled into relationships with digital health companies that go outside of your system. That's how I would first say it. Jim, anything you want to add there?
No, I think you're absolutely right, Lisa, and thank you for highlighting that. So essentially, to the health system, there is no investment, there is no upfront cost, there's really no risk. When you engage with a participant who is already in access, when you engage with Innovator specifically, we would be routing the co-management fee back to the health system. The upside on potential payments, that's a risk burden that Innovator would be taking on, but beyond that, there's really, and I think that's separate from any risk that the health system would bear. So there's effectively no risk to the health system, and we, as the participant, are taking that on.
Yeah, and I'm going to have something shared in the chat. CMS rarely puts out materials that are really helpful for providers and health systems, but they actually put out, I think, a really helpful webpage in the last couple of days that is really directed towards providers, to physicians, to those who might be affected by this model, but not actually the direct participants of it. So I'm going to have that shared in a moment here in the chat. Jim, I know we have to get to lead, so if you want to jump ahead to that.
Yeah, absolutely. All right, thanks for leading us there. So moving from access to this other new program, I think that this is again going back to the tensions and intentions that John described. This is another program that has similar thrusts as access, but obviously different mechanisms. So let's talk about that a little bit and what it takes to be successful within LEAD. I think when we think about LEAD, it's really the and I'll call back to different terms that folks that have been in the VBC world might be familiar with, but essentially this is maybe you can think of it as a next generation of ACO reach. But effectively, to be successful in LEAD, it really requires organizations to do six things really well. You can see them on the left here. And these are not inherently new, I would say, but the degree to which you need to be mature in doing these things, in stratifying your populations, in forecasting benchmark performance against benchmark, to document precisely, to close gaps, and this may be where it does differentiate a little bit, but optimizing specialty care and then minimizing avoidable utilization, especially for high needs populations. So these are things that, in theory, all population health companies should have been doing for some time. What LEAD does is it requires that organizations do these much faster, much more seamlessly, and much more precisely. And so to put that in concrete terms, let's compare against, on the next slide here, against ACO REACH, right? So you can see some of the differences in terms of, terms, in terms of where quality measures are and how the payments really work. But effectively, what that means is that you have a longer risk term, and then and the stakes are higher because of capitation, and the focus is a little bit different, shifting to specialists and high needs populations within LEAD. And so again, that means you as an organization that's wanting to participate in LEAD need to be very nimble, much more reactive and prescriptive about how you take on these populations, and ultimately drive this as opposed to wait for some of these mechanisms to happen. And so we'll also do a similar comparison between, so if you're an organization that has been in reach and using some sort of OS, such as the Innovator operating health population health operating system, there's a natural bridge. That's what's depicted here. There's a natural bridge between ACO reach and going lead. So you're ultimately primed for success in lead because all of these components, the actuarial intelligence, the managed programs, the operating system will scale and be effective in lead in the same way that it was in ACO reach. So that's a natural bridge there. If you're coming as an organization from the MSSP side, there is a little bit of a difference, and there's much more, I think, much higher sort of risk tolerance between MSSP and lead, much longer term, as previously stated, but also in terms of the payment mechanisms and the even down to some of the details around risk adjustment, there is a natural shift, and it's a further requirement for precision and speed to be successful in lead, right? So ultimately, what that means, I think, for these organizations is to think about kind of 4 pillars on the next page, which is that you have to be agile and great at data integration. That's not an optimization in lead. That's a prerequisite. That's kind of a requirement for participating. If you're on sort of a manual identification and stratification of populations and who's at risk, that really needs to migrate to a much more mature level. Within the MSSP baseline, you also had minimal sort of specialist care integration. Now there's, this is through the introduction of CARA, a much more fully integrated specialist component to it, which means ultimately, from an actual modeling perspective, you could have, gotten away with basic scenario modeling on the MSSP side, but in lead, you really need to be predictable, precise, and be able to forecast your outcomes. So really, we see this as essentially a maturity play where on an MSSP baseline, you could be successful doing it the quote unquote traditional or old fashioned way. But in lead, it's really kind of a shift towards maturity. And you really need to be much more sophisticated along these 4 different dimensions, but also be able to do them not just as separate projects or separate work streams, but in one unified, seamless, integrated platform. And that's how we see kind of the difference between MSSP and lead. So ultimately, you're still kind of doing a lot of the, at the first principles level, much of the same thing, which is identifying beneficiaries and particularly high needs beneficiaries. You want to be able to then automate the prevention plan and the quality plan. And so it's not simply identifying them, but connecting them then to AI-enabled care management, which is then connected more seamlessly to the point of care solutions and the ability to actually close those gaps before the withhold is lost. And then ultimately you're maximizing shared savings if you can also integrate with specialists and understanding your sort of contract performance on the whole spectrum there. So again, this is essentially a shift from lesser maturity to more maturity and integration across the spectrum and the continuity of care that you see depicted here. Right? And so if you're at this point wondering, which program is right, that's something that our Humvee division within Innovator can absolutely help with. Is it sufficient for you to stay in MSSP, or is lead actually the right sort of play for your organization? That's something where we can look at the data that we have access to through the VRDC and help understand what is going to be best for you. All right, so taking you all through a whirlwind. I think that tees us up for really what is necessary, what's happening under the hood to enable all of these components, and I'll pass it over to my colleague Varun to talk about that.
Hang on one second. We have one other question I want to at least briefly address, and that is, can you comment on the benchmarking process for MSSP versus lead and the pros and cons to stay or leave MSSP? That's a little out of scope for this webinar. but we're happy to follow up with you. However, if you're looking at this year, just know that unfortunately the deadline for lead has already passed. So many folks have already made that painful calculation. But we are very happy to follow up with you if you want to reach out to, it says you're anonymous. So if you type this, please send a message to the hosts and panelists or the host with your information, and we're happy to follow up with you directly. Okay, Varun.
Thanks so much. Thanks so much, Lisa, and thanks so much, Jim. So those of you who are familiar with Innovaccer probably know Innovaccer as a provider of population health or VBC technology. So you may be wondering, how can Innovaccer actually scale our chronic care management programs? And that's what I want to do today is talk to you about the technology that actually we've developed that lets us do that. So I would say that right now, traditional chronic care management is built really around conditions and not around people. So every time there's a new condition, that's a new enrollment, a new care manager, and your infrastructure gets heavier and heavier. And that's why many chronic care programs can only reach the highest risk patients, and then they leave all the others basically unmanaged just because they don't have the capacity between their human resources and care managers. So then those people don't show up as risk until they're, in the ED. And what API or adaptive program intelligence allows us to do is really flip this model and lead with AI first chronic care management. And that dynamically adapts intervention intensity to in real time based on patient needs, conditions, and response patterns. So by being AI first in our chronic care management approach, that allows care managers to focus on patients and situations where they can move the needle the most. And the impact to your chronic care management program by using a technology like adaptive program intelligence is that the cost per patient drops as your enrollment in that program grows. Whereas typically you'd have to scale quite linearly by adding more care managers. Now, because the AI is automatically orchestrating between AI-led care and human care, that actually scales the effectiveness of each intervention, each outreach, thereby dropping the costs. And I think what really differentiates it is this longitudinal learning. And that means that the system gets smarter over time. So every signal, escalation, patient response feeds into how care intensity is assigned across the whole population over time. And I think that this is in line with how CMS is thinking about this because CMS signaling they're going to pay for outcomes-based tech-enabled care at scale, and adaptive program intelligence is the technology that really makes that viable. So the last thing we're going to leave you with before our expert panel discussion is a short 100-second video that gives an example of how exactly it works.
Today, most patients with chronic conditions never make it into a care management program because traditional approaches simply can't scale. The result? Higher costs and worse outcomes for the patients who need care most. Atlas was built to change that. Introducing Adaptive Program Intelligence, the industry's only solution that watches how every patient responds and dynamically adjusts their care intensity in real time. The adaptive care model means no fixed tier assignments, no rigid workflows, just care that evolves and moves with the patient and adapts to their unique needs. AI continuously evaluates every patient, escalating or de-escalating care intensity in real time. Every patient, every program, all easily managed on one operating system. Let's take a look. Meet Maria, enrolled in a diabetes program with AI-powered monitoring. When her lab flags developing hypertension, adaptive program intelligence doesn't create a new program. It layers the protocol in automatically. Same care team, unified view, seamless experience. And when Maria stabilizes, the system de-escalates her care intensity just as intelligently. Atlas makes care continuous, intelligent, and personal. ensuring patients with chronic conditions get the care they deserve while reducing costs for provider organizations. That's adaptive program intelligence.
Great. So I hope that short video showed you how you can scale chronic care to every patient that deserves it. So with that, let's shift to our expert panel discussion, and I'll pass back to our moderator, Lisa.
Great. Okay, so lots covered here already today across the opening around the general policy situation that we're in, and then some specifics around how Innovaccer is looking at access and lead. So John, I want to start with you in this discussion. Now we'll get a little more tactical now than we were before. When you're thinking about organizations that have historically outperformed in value-based care programs, what have you seen that they have in common operationally? I'm sure over your career at CMS, you interacted with many health systems providers, physicians, and those who are involved in these models or had questions about them.
Yeah, it's great. It's a really good question. I mean, I think, there's certain attributes that CMS saw of culture, leadership, commitment to value-based care by the line physician staff. But I think for purposes to this conversation, in addition, is really having great insight to the patient. And I think what CMS is seeking, and I think it's really evident in new model development, is that organizations are engaging patients that can most benefit from care coordination intervention. I think those provider systems that knew their population well, that had very strong relationships with um, uh, uh, post-acute care providers, physician specialists. There were certainly providers that won by coding improvements, etc. And those are important, but what I think CMS wants to see, what CMS really respects, is those organizations that can identify patients, that can engage patients, that can demonstrate that engagement, that know how to connect the system together to ensure patients don't fall through various gaps or cracks in care, but it's that engagement, the theory of change, the commitment to the better patient experience, and um, true value being produced in the program.
Yeah, thanks. That makes total sense. Jim, let me just actually flag the same question to you, right? From all of the work that you've done, all of the customers of Innovaccer who you worked with in different ways, like anything else jump out to you in terms of things that separate organizations who are performing highly in value-based care programs versus those who are struggling?
Yeah, I mean, so I think what I've seen is there's a very obvious maturity curve and a very obvious maturity spectrum that different organizations are on. Yeah, I think the good ones, the ones that are performing successfully, are staying true to kind of the first principles of really kind of feeding what I call this loop of understanding where you need to be strategically, then getting tactical, then deploying the right interventions, and then ultimately measuring that. And so if you do this cycle well, then I think you end up with, understanding where you need to be and where you're not and where you need to be, then getting down tactically to address those needs, and then ultimately deploying the right interventions at the right time. And so I think the correlation that you see is that the organizations that can do that cycle really well are probably the ones that are leveraging technology in the more meaningful way. Um, so I think that would be a component of it. The other component of it that I think is often overlooked, that I guess is, and there's a little bit of bias from me for given my sort of analytics background, but I think assessing and sort of forecasting where you might end up, is often a lever that I think organizations don't always think about. This is ultimately a risk sharing arrangement. It's a value-based care is that. And just like the payers, you need to know what risk you're taking on and for whom you're taking that on. And if you can know that before you kind of say yes to taking on that risk, there's a higher chance of success there.
Yeah, I mean, I think depending on where you sit, right, a value-based care model, a value-based care program is about who takes on what risk where. However, the way that the dollars move, the way that providers, physicians at the point of care suddenly have a little bit more flexibility in how they deliver that care, um, one of the most meaningful things that will actually affect patients, will actually affect physicians and clinicians, is that flexibility in how care is delivered that may meet needs better, right? And that's what when you talk to physicians who are at the front lines or clinicians at the front lines of delivering care in value-based care models, they really do appreciate that change to care delivery as well. But you have to be in a situation where they can actually lean into that and then redesign how they deliver care in a way that is, more meaningful for patients, more meaningful for that way of care management. Picking up Jim on what we were just talking about with the population health operating system and adaptive program intelligence. We talked about it, in the sense that this is the infrastructure that we believe in, that we have learned well over a decade, supporting healthcare systems, providers, ACOs, and others in being successful in these accountable care models. How are you in your work, Jim, advising health systems, health system leaders in there about their readiness for these models, right? How are you helping them understand? I think you just said a piece of that, which is that, you got to be able to measure where you are and where you need to go first and foremost. That's very important to know where you're
Right.
starting and where you want to go. But also, how are you helping them understand the gap in their infrastructure that will maybe make them more successful or less successful in programs like Access and Lead?
Yeah, and so great question. I'll actually touch on a few things you mentioned as well. But I think the first thing to understand is with these new programs, the longer commitments, like the 10-year commitments with real dollars against real outcomes, that just means, I go back to what I was referring to during the slides, which is that the stakes are higher, the risk terms are longer, therefore the need for precision and speed to action in a very nimble way, which I think is what you highlighted, is a adaptive and nimble way. That requirement is much higher for these systems, and I think so. I would ask every organization to think about three questions. Concretely, can you assemble like a longitudinal view per patient and then be able to act on that, whatever you see within that longitudinal record? Can you also adapt your care model against these new economics? I think is the second question I would pose is, I think there's a lot of financial metrics associated with some of these payments for outcomes and so forth, but inherently it's calling for more AI-led care models. And so if you have a traditional care model, you really need to look at the economics of that to see if it will survive kind of the financial economics of these new programs. And I think the third one is kind of, again, going back to what you're alluding to, which is, can you triage the intensity of different patient needs in an algorithmic and sort of AI automated way, and then be able to deploy, whether it's AI-led solutions or human intervention, to ultimately impact outcomes, right? So you really need to kind of understand the variation within the population and then tailor the care model appropriately at appropriate times for those individuals. So those are be the three questions I would ask. And I think like fundamentally, we still see organizations that are running very siloed data sites, some manual identification of opportunities, very retrospective analytics, and then a very traditional care management system. These new models call for maturity in all those aspects. And because I think the other thing to really think about is that these solutions that you choose today, the commitment is long, right? And so the technology, the process, the people that sort of go into all of that needs to be ready for the long haul, right? I don't think we'd all want to imagine potentially switching any of that once you enter into some sort of commitment like this. Could you really imagine doing that midway? And so because the structural choice locks you in, to use the words of the youth today, you really need to lock in as well in terms of your capabilities. So
Great. So moving back to you, John, there is a tension in both of these models, access and lead, between the clear ambition and also what we know is really important, which is continuous connected care. The reality that most organizations are still delivering care in a very episodic fee for service manner. So, we don't have as much adoption throughout the entire sort of value chain or delivery chain as we would hope. So, ambition, experience that we all have around continuous and connected care, and then the reality where we still have a tremendous amount of care being delivered very episodically and in a fee for service manner. Um, you know, where are we in this sort of transformation chain? It's been many years now. We've just spoken about them, and how much time do we have? What is the patience for this, for letting this evolve as providers and health systems get on board over time? Where are we in that process?
I mean, I don't know that we're in the last inning, but I think maybe we're in inning 6, 7, or 8, meaning that, well, there is, continuous um, focus to how we build better models for the Medicare program. At some point, the patients will run out. That if we can't find, definitive savings, we can't find definitive quality improvements. I think, kind of one core message that I think we're all saying regarding lead and access is um, the future is uncertain. So those providers that participate will help define that future going forward. And at some point, potentially that, 10 years down the road, that if we can't together collectively demonstrate better outcomes and better results for the taxpayer, that the options might get worse, meaning that you might see more dramatic fee cuts rather than more incentives to join these models. I think, to your question, Lisa, regarding kind of how can we move away from fee-for-service Medicare, um, that really is, the tension, just to come back to that theme, that we want both at the same time. We want that patients have the right to choose, particularly within traditional Medicare, the providers, hospitals they want to see, but at the same time that we create systemness, that we create an experience where by staying in a system, participating within team-based care, we get better results, we get better outcomes, we get better patient satisfaction. So, back to your earlier question, those systems that should win will be those that can do both at the same time. They're honoring patient choice, they're honoring patient preferences, but they're also creating the systemness where the system begins to embrace the patient when he or she goes through a brand new diagnosis or a catastrophic diagnosis. And rather than having the patient navigate a complicated system, the system works to embrace that patient, works to carry that patient through a complex a care plan, a new diagnosis. So what I think policy, what I think the um, community is pushing us to do is to both at the same time. Give patients the freedom that they want, but create the system where the patient stays with the care team, follows the care team, and feels far more safe with that care team.
Yeah, very helpful. I'm just going to quickly address a couple of questions that came in before we get to the closing section here. We have a question about the adaptive program intelligence. How can it be trusted with an AI-driven solution? Is it auditable, explainable? How decisions are made? Are the decisions consistent and equitable? And how do we know and confirm that? This is a big question that we can't fully address here, but it says you're an anonymous attendee. If you want to reach out to us directly, just respond in the chat to the host, and we're happy to spend some more time with you. I'll just say very quickly that everything that we do is driven by the physician and the clinician at the point of care. Humans make final decisions. These tools are helping deploy care management at scale when there aren't enough people in the system and enough touch points to keep people moving forward. So these care plans and the direction to do this work is all, on behalf of the physicians and the clinicians delivering the care, and part of systems that are auditable, transparent, and provide all of that information back to those treating physicians and clinicians. So just a few notes there, but we'd be very happy to spend some more time with you and talk more about this in depth, so we don't go too far off base here. But do feel free to send us a message here in the chat to the hosts and the panelists with your information, and we'll spend some more time with you on this question specifically. Moving on to another question, Sam Hyatt asks, with LEAD's CARA enhancement and models such as the ambulatory specialty model, do you see risk further shifting to include specialist and total cost of care accountability? Sam, I'll give you my really quick answer, and then I'll ask John and Jim to chime in here. I think that the best place for the total cost of care risk generally is with the source of primary care. But of course, the actual costs are far outside of that scale. So I think something like CARA, whether CARA is successful or not, which is bringing in a structured way for primary care at risk for total cost of care to contract for specific amounts with specialists. I think that it's critical. I don't know if this is the right model, if it's going to necessarily work. It's very complicated and hasn't started yet, but I think it's incredibly important for the future of success in total cost of care models. John, Jim, any comments on Sam's question?
No, I think you answered it really well, Lisa. I think what CMS is trying to do is to incent the primary care locus to be the stewards for how patients get referred for care, to promote more relationship compact with the primary care physician and the specialist, particularly for kind of high volume physicians that serve the Medicare population. But I think ultimately the question of risk will be designed by the ACO, but the intent is to really create stronger partnership, create stronger referral, but also feedback loops for the care plan, the care needs, and the total care management for that patient.
Great. Anything else to add, Jim? Okay, well, we're gonna move to our final question because we're almost out of time now. 5 years from now, we're like halfway through these models. Which of these two models, Access or LEAD, do you think will have moved the needle the most on patient outcomes, and why? This is your lightning round. Jim.
So in my mind, they're actually complementary in nature, but because LEAD, I think, is more at its essence, maybe a more sophisticated financial model. I think there's organizations that could probably be successful in LEAD just by staying under the benchmark. Therefore, my answer is actually Access. I think Access has financial outcomes tied directly to clinical outcomes. And so if we're talking about moving patient outcomes in 5 years, you're going to see that more on the Access side.
Okay, John, you're up.
I don't disagree with the analysis, but I would say from an aspirational perspective that LEAD, any model that's incorporating total cost of care, really I think is the premise for the future, with Access being a key enabler towards meeting those total cost of care goals. Short term, totally agree with Jim. Long term, I'll place my bet on total cost of care models.
Right. Okay. Well, I think there might be one more slide here at the end, maybe a QR code. There we go. So thank you, everyone. Thanks, John. Thanks, Jim, for your time, Varun, and everyone who attended. If you want to scan this, you will be able to set up time with us if you'd like to. You can also message our team here on the chat. Again, the questions we couldn't go into depth on, we're happy to answer. Please reach out if you have further questions there, and we'd be happy to work with you, advise you if you're thinking about Access or LEAD, and are looking forward to the upcoming launches of these two pretty consequential models for CMS and for the future of value-based care. I think that's everything we've got. Thanks again for your time, and I'm happy to catch up with you on our next webinar or our next event together. Thank you, everyone.
Thanks, everyone.